Welcome and good afternoon. My name is Dr. Joy Coles, and I serve as the inaugural chair and DNP program director for graduate nursing education at Morehouse School of Medicine. And I currently practice as an advanced heart failure, heart transplant, mechanical circulatory support, cardiovascular nurse practitioner. I want to first thank the Georgia Commission on Women and the Georgia Nurses Association for the honor of presenting at the sixth annual Virtual Georgia Wellness Summit. It is an honor and a privilege to be in conversation with you this afternoon about a topic that is, in many ways, the central public health story of our time: cardiovascular or heart disease, the number one killer, and the conditions that fuel it, and the rising or rolling tide of heart failure that is following close behind it. The title of today's talk is Defending the Heart: Connecting Prevention, Chronic Disease Management, and Heart Failure Risk. This presentation has a keen focus on addressing multiple factors, including the social drivers that shape heart health across our communities. Over the next 35 or 40 minutes or so, I hope that whether you're a clinician, a nurse practitioner, an advocate for patients, or a community engaged member, that you'll leave with a clear understanding and sense of what is happening on the cardiovascular or heart continuum and why it's happening and what each of us can do about it. Before we begin, I have a brief disclosure, but no relevant financial disclosures with any companies to disclose. The content I'm sharing today, however, is independent educational material. It does not represent the official views or position of the American Heart Association, the American College of Cardiology, the Heart Failure Society of America, the Preventive Cardiovascular Nurses Association, the American Association of Heart Failure Nurses, the Georgia Nurses Association, or Morehouse School of Medicine. But I will be sharing today information that is grounded in published information and guidance from each of these respective organizations, and the synthesis is my own. So here are some learning objectives and what we're going to cover this afternoon. So here are five objectives that'll guide our time together. First, I want to make certain that we all leave with a clear understanding, working from the same mental model of cardiovascular disease continuum. The model that the Joint Cardiology and Heart Failure Societies have adopted in 2022, and we'll talk about those, which traces patients from at risk for heart failure all the way into the continuum of leading into advanced heart failure. But second, we'll also learn about how Life's Essential 8 function as the prevention framework that operates upstream on the heart continuum. Third, we'll examine how social drivers or social determinants of health, basically those conditions where people are born, they live, they work, they play and age, accelerate the journey from cardiovascular heart risk to actual symptomatic disease. Fourth, we'll talk briefly about the disproportionate burden on women, on rural communities, and on systematically disadvantaged populations, especially here in the American South, including, and importantly, Georgia. And finally, we'll close out this afternoon's talk with concrete actions, something sustainable and scalable to draw from the major professional societies that I mentioned briefly before, from my own nursing practice as an advanced practice registered nurse, and information that really truly all of us can take regardless of our role, because we all live and engage in our own communities. So let's start with some awareness. The numbers don't lie. And unfortunately, these numbers are going to frame the way we have our conversation this afternoon. In 2009, the American Heart Association reported that 65% of the women in the US have known or they knew that they had heart disease or cardiovascular disease, not breast cancer and not even the other cancers combined. It was understood that heart disease was the leading cause of death for women. However, let's fast forward to 10 years later in 2019, and that number unfolds to be 44%. There's a 21% point decline in a decade where the field had investigated heavily in awareness campaigns. We see them on our televisions during our commercials of our favorite shows. But nonetheless, there's been a decline in women really understanding and knowing that cardiovascular disease is the number one driver of death among women. The steepest declines are among women of color and the very populations who carry the highest burden of cardiovascular disease itself. But what does this tell us? It tells us something uncomfortable, but very important nonetheless. That awareness by itself is will not hold the line. Awareness was the first point of defense. And in some ways, we can say that it has slipped. We need a different strategy. We need an improved strategy, I should say. And we need to connect the work of prevention, the work of chronic disease management, and the work of heart failure into single coordinated approach. That is what we're going to talk about this afternoon. So in 2022, the American Heart Association, or the AHA, the American College of Cardiology, ACC, and the Heart Failure Society of America, HFSA, jointly published heart failure guidelines, new guidance that did something very important for all of us in academia, as clinicians, and even the community as a whole. They redefined, restructured really the stages of heart failure to put prevention first, to put prevention at the very center. So, stage A is those who are at risk for heart failure. It's now clinically defined by any person with high blood pressure, hypertension, diabetes, obesity, or metabolic syndrome. No symptoms are required. No structural changes have yet happened to the heart, but the person is on the path. Stage B is our pre-heart failure stage, meaning there has been some structural changes. They've started. There's some blood markers that may be elevated, like the BNP. The heart is changing, but the patient still feels fine, or the person still feels fine, right? And in stage C is symptomatic heart failure. This is what most people know and understand is heart failure because patients or people at this stage experience things like shortness of air, what we call shortness of breath, fluid retention, fatigue. They feel tired. And in stage D is advanced heart failure, where the symptoms have become at this point refractory despite therapy, and even if therapy is optimal. And this is the world that I've honestly practiced in clinically for many years and caring for patients who have required either mechanical circulatory support or an artificial heart pump, or ultimate or heart transplantation as well. So the thing is, what we really want to internalize here is that heart disease or cardiovascular disease and heart failure are not two separate things. They're not two separate stories. They're on the same story at different stages.
It's 4 o'clock.
So the earlier we recognize where someone is on the heart continuum, then the more we can change the ending. And that's where prevention come in. And prevention, as we all know, is key. In 2023 and 2024, AHA also gave us a way to act on the continuum at the bedside as bedside nurses, clinicians, advocates. And it gave us a four-step workflow. Screen for the risk, using those life essential aids, and assess the overall heart risk to that person. Determine where they are on the continuum, what stage. These tools were developed as major risk, cardiac risk calculators that helped with heart failure prediction. This directly supports the central argument, even for what we're discussing this afternoon, that primary prevention is heart failure prevention. So again, in 2022, the AHA also introduced within its Life's Essential Eight a framework of measuring and protecting heart health across a person or individual's lifespan over the continuum of their lifetime. It has two parts essentially. On the left half, you have four health behaviors, one being that of diet, a person's physical activity, nicotine exposure, and one of the newest additions, sleep health, sleep hygiene, and its importance. These are the daily, ongoing life happenings, choices, and conditions, even that shape heart health risk over a period of time. On the right, we have four health factors: our body mass index, blood lipids or cholesterol, our blood glucose or sugar, and blood pressure. These are the measurable clinical indicators where the body starts responding to those stressors, that to the inflammation, to those behaviors, to those exposures, and you start to see symptomatic disease show up. So each particular metric or measure is scored from 0 to 100, but your overall cardiovascular health score is the average. And so the higher the score, the better things are in regards to the higher the score, it correlates with the lower risk of heart disease. So the lower the risk of heart failure, it ultimately longer life. So again, if your score is higher, it means your risk of heart disease is lower, your risk for heart failure is lower, and it equates to longer life. So here's the way I'm kind of packaging this and how I would like for you to hold on to this framework. Life's Essential Eight is not a checklist. It's not for us to feel guilty about what we can and cannot do, or even things that we can't even control or change. It's the prevention infrastructure for heart health. So when it holds, then heart health holds. And when it breaks down, unfortunately, we get the rest of what we're going to talk about this afternoon. So I'm going to spend a moment on the evidence, right, in the literature, the publications that informs us, the science, because this is the part where we can talk about how Life's Essential Eight is not just an awareness campaign. It's a tool. It's something you can use to measure, and it has demonstrated impact. So studies have shown that individuals or people with heart cardiovascular health or heart health is defined as an LE8, and I'm using the abbreviation or acronym LE8, meaning Life's Essential 8 score of 80 or higher, have about a 74% lower risk of cardiovascular events compared to those who do not or who have poor heart health. That's big. That's a huge percentage of people with lower risk based on that calculated score. Many of us know about the Framingham Heart Study, which is one of the longest running cardiovascular or heart epidemiology studies in the world. And it found that participants with an LE8 score above the median of 68 had about a 53% lower risk of heart disease incidence and a 45% lower risk of all cause mortality. Again, the numbers are the numbers, and the numbers are objective in that it is shown here across this very large longitudinal study that when patients have better heart health, when you utilize metrics like LE8 to be able to help patients understand their score, you have a real clear picture of a person's risk. And these aren't small effects. These are the kind of effects and really truly big things in any other field that would be front page news. These are things we would be talking about on many platforms. We have a framework that, when applied consistently with with the patient's or person's population, it can potentially reduce cardiovascular events and extend lives. But we must know first. So the question isn't whether prevention works. We know prevention does work. What we have to ask ourselves is, what about those who have access, and can we make prevention possible? And that's going to bring us to discussing more about what stage A does, right? Unfortunately, stage A holds true for a lot of patients. I would reckon and even argue that this may be one of the most important points of this talk in this slide because this is an important point to note. The 2022 AHA, ACC, HFSA guidelines define stage A as at risk for heart failure. So that's going to be anyone with hypertension or what we call high blood pressure, diabetes, obesity, metabolic syndrome, or related conditions. Again, remember the people with this particular stage have no symptoms. There's no structural heart disease to note. And they may even have perfectly normal numbers or cardiac, what we call cardiac biomarkers. But by the definition in and of itself, look at our population. 120 million Americans have hypertension, 100 million with obesity, and 28 million with diabetes. There's a large amount of overlap as it relates to these groups, but the total number of US adults who meet the criteria of stage A, given this, is pretty quite staggering. So these aren't just people who are going to develop heart failure someday in the abstract. These are patients who, by current guideline definition, are already in stage heart failure, right? Stage A, right now, today. But prevention is key. Let's talk about it and let's do something about it. So here is what they have in common. Most of them, most patients, most people, individuals in this category have no idea. We all have heard many years that high blood pressure can be a silent killer. So oftentimes at our primary care or at their primary care visits, it can sometimes be framed around managing your chronic disorder like high blood pressure, or managing your blood sugar. But sometimes people aren't told that we're managing the heart failure risk. Packaging it in that way, that language and that particular connection is what is going to make the clinical encounter completely different for most individual patients. So, chronic disease management is heart failure prevention. It's not just about controlling your blood sugar or your diabetes, it's not just about controlling your high blood pressure. Now we're talking about preventing heart failure. And it's just not called that as often. So let's walk through a little bit here on how hypertension or high blood pressure drives heart failure. And then look at how we package that, how we understand that. And I'll be honest, most clinicians, or I wouldn't say most, some clinicians have not been taught the connection in this respective way. So the step one is that you uncontrolled blood pressure means that the left ventricle is pumping against a sustained elevated pressure load. Every beat, every day for multiple years. That uncontrolled blood pressure is pumping right against a sustained elevated pressure load within the left side of the heart. Step two, the heart adapts though. I always tell my patients the heart is the one muscle you do not want to get bigger. So the way that the muscle adapts to the load is that it gets bigger, it gets thicker. And we call this left ventricular hypertrophy. It looks adaptive initially in the short term, but over time, the ventricle becomes really stiff and it can still pump blood out, but it's harder to feel over time. And we call this diastolic dysfunction. And then there's step three. That stiff, hypertrophied or enlarged heart that doesn't feel very well as far as the ventricle becomes symptomatic. And now the patient, the individual develops things like shortness of breath, fatigue, leg swelling, or what we call edema. They're sent for an echocardiogram, or we call it an echo, an ultrasound of the heart. You may see, or they may see, the patient may see that the ejection fraction, or how much blood is pumped out, comes back normal. It may say 60%. But at that venture, they're diagnosed with heart failure with preserved ejection fraction, or HFpEF. This is one of the most common forms of heart failure in women, and it traces back to the vast majority of the cases from years and years of uncontrolled hypertension, uncontrolled high blood pressure. This is the single largest preventable driver of heart failure in this country. So, the burden of uncontrolled hypertension or high blood pressure falls hardest on women of color, on Southern women, and on women with limited access to care. And that's why it matters. So, again, hypertension is the silent ramp. It leads up to what we know as stage A heart failure, which again, the focus is needs to be on prevention. Let's switch gears a little bit here and talk about a metabolic accelerant. Essentially, diabetes, unfortunately, does damage to the heart through multiple pathways. Specifically, the three distinct pathways that we're discussing is through one of the things that makes it so powerful as an accelerant. Diabetic cardiomyopathy, which is often driven by hyperglycemia or high blood sugar, means that you have chronically elevated blood sugar or chronic elevations of your sugar levels or glucose levels in the blood. This this inflammatory process directly damages cardiac muscle cells, so heart cells, the muscle cells specifically. And this is independent of someone having coronary artery disease. So an individual can have completely clean arteries, coronary arteries, and still develop heart failure from diabetic cardiomyopathy, which is unfortunate. So prevention is so key in that understanding. Microvascular injury can also happen. These are the small little blood vessels in the body, like capillaries, and they can be damaged as well by high sugar, especially when hyperglycemia is sustained. This impairs oxygen delivery to the heart muscle, to the myocardium, and to every other tissue in the body as well. And so we see this when diabetic patients have issues with their eyes, their retinas, the kidneys, the nerves with neuropathies, and the heart. And so, third, an accelerated atherosclerosis, it also can be imminent. Insulin resistance, dyslipidemia, high cholesterol, and the inflammatory process that diabetes causes drives this cardiac artery disease that becomes diffuse, more aggressive, and is markedly different from patients who do not, or people who are not living with diabetes. So now, here's the critical point I want to make. When a woman is living with both high blood pressure and diabetes, and the numbers, the statistics tell us many of them are, the risks do not simply just add up, they actually compound. And so, a heart that has been under chronic stress with chronic high blood pressure is already stiffed and overworked. And so, now add insult to injury with a metabolic environment of diabetes, which causes this whole inflammatory process and accelerates the damage to already compromised tissue. So, the result is accelerated heart risk as well. And patients need to know. So before I move on, I want to acknowledge something really important. I've spent a lot of time really focusing on high blood pressure, diabetes, focusing and kind of highlighting stage A heart failure, and that having a conglomerate of those particular chronic diseases is indicative of stage A heart failure. And the focus needs to be beyond just awareness and shifting more into prevention as well. So, as we spent that time, I also want to talk about an intersection of other disorders. And because diabetes and hypertension are the two largest, they're the most actionable, but they're also the most inequitably distributed when it comes to the precursors that we acknowledge and put attention to for heart failure. So they're not the only intersection. So stage A, as we talked about earlier, is a wider story. The 2022 guideline named obesity, chronic kidney disease, and sleep disorders. So including obstructive sleep apnea, which often goes undiagnosed. So, smoking and nicotine use, metabolic syndrome, cardiotoxic exposures, all of these, including some cancer treatments, including breast cancer treatments, can lead to stage A. And these are all contributors, and people need to be aware. So I focus on hypertension and diabetes because they're the most common, but they also touch the highest number of women within our communities. But the framework holds true across the continuum and for the other intersections as well of these disorders. So the focus is chronic disease management. The principle is the same. When we manage the conditions well and we coordinate care, and we have a focus on the social drivers that impact the care, we can defend the heart upstream. Prevention is key. That is the work we all intend to do. So, we're going to sit here for just one moment and talk about the downstream price. We talked about what we can do upstream to prevent, but the downstream price is what the numbers that we're seeing already. So, between 2017 to 2020 and 2021 to 2023, those reporting cycles showed that there was a prevalence of heart failure in US adults that rose from 6.7 to 7.7 million, an increase of 1 million in under 5 years. Demographics tell us that aging is not the only population, it's not the only contributor, right? We know we have an aging population and it does account for some of that increase, but for not for all of it. So there are multiple analyses out there that have concluded and explained that the demographic isn't just aging alone. It's the cumulative effects. It's all of it combined together, a poorly controlled high blood pressure, uncontrolled diabetes, obesity, chronic kidney disease, and social conditions that actually make this harder to manage. So, heart failure is one of the few heart conditions whose rate is actively actually growing, increasing, and not declining. We've seen over the past years acute myocardial infarction or heart attack mortality come down some. We've seen stroke mortality come down some, but heart failure prevalence is increasing and it's projected, unfortunately, to keep rising through 2050. So this is what happens when the prevention system is not working as fast as the care system can catch up. So the price ultimately paid is undefended chronic disease management, making an increase or impacting and rising heart failure prevalence. And we need to stop and slow it down. So this is where we pivot in our time together this afternoon because everything has led up to prevention, chronic disease management, and within a framework that assumes sometimes that people have conditions to act on it. And that assumption is not equally true and it's not equality. Look at what each life's essential aid actually measures, and let's compare that in the real world. A healthy diet requires access to affordable, fresh food, right? If you live in a food desert, and millions of Americans do, especially in rural areas in the South, the structural reality is that healthy food is not even available. It's not a reasonable ask, and it's not within a reasonable distance to even acquire. Physical activity requires safety, it requires available time, physical energy to do so. And if the neighborhood doesn't have sidewalks, if an individual is working multiple jobs and they're exhausted from caregiving, exercise isn't a plan, it's a task. And at best, it's hopeful, it's wishful thinking. And sleep health requires work schedules and housing that allows one to actually rest. So people who work night shift or multiple jobs, parents who have little kids, people in unsafe housing areas, sleep is not necessarily a choice, and sleep hygiene may not be the priority. And blood pressure control requires meds, and that costs money. Regular follow-up visits and trust in our healthcare system that unfortunately has sometimes failed the very patients sitting in front of it, that we're designed to serve. So, life's essential aid sounds like personal accountability for an individual, but it's actually a measure of social infrastructure. And it helps us rethink about the changes that need to take in place in order for us to actually approach prevention. So here's something that is good news. When the AHA released the Prevent study in 2023, they did something that none of the other major cardiovascular risk calculators had done before. They actually incorporated a social deprivation index. And basically, this just meant that it was based on a person's zip code. So this was a direct estimate of neighborhood level disadvantages, and it put it into a clinical risk estimate. So for the first time, a major cardiovascular disease risk calculator actually looked at the impact of where you live, where you eat, grow, learn, and play, like your social drivers, determinants of health, on your heart. So the 2023 AHA scientific statement on cardiovascular disease risk in women, led by Dr. Mehta, actually looked at and they linked the social drivers or determinants in cardiovascular outcomes to make them more clear. So the statement actually named 5 domains, and it's drawn from the Healthy People 2030 framework that essentially highlights the different various areas or domains in which we consider to be social driver. And so that essentially helped understand who developed hypertension, who developed diabetes, whose economic stability helped us understand, who would progress to heart failure and who could even eventually survive it. So neighborhoods and built environments were important and informative. So educational access as well was very important, and healthcare access and quality of that healthcare was also important. Social and community contexts were key. So let's be clear a little bit about this statement in saying social drivers of health are not necessarily background and contextual. But they're not small factors either, and that we acknowledge that we can't just move past them. They are part of the mechanism. They are causally connected to who may individually develop or end up developing heart disease, and at what age, and what controls their circumstances and situations around control of their high blood pressure, who fills their prescriptions, can they walk safely in their neighborhood, who is hurt in those clinical encounters as well. So when we treat social drivers as a mechanism, as a means, the question stops really being, should we screen, but more so on the continuum of how do we intervene? So one important note that I want to make as it relates to health equity is that the newest cardiovascular risk tools no longer use race as a variable. Instead, they incorporate zip code, but they still do not fully capture individual experiences of being structurally disadvantaged, in my opinion. Advancing health equity and cardiovascular care will require continued attention, continued research, and commitment to making this work across the heart continuum. Another study that we can briefly chat about is Liu and colleagues, and they did a fascinating analysis that looked and mapped heart failure mortality county by county. So they went across, they used this data from across the US and asked what explains different geographical variations. And so the answer was quite um, um, informative. The variation was explained by four factors at the county level: diabetes prevalence, hypertension prevalence, obesity prevalence, and physical inactivity. So these factors have been essentially what pulled together to show that geographic variation is what we've been talking about this entire time. So heart failure mortality is not just randomly distributed across each part of the country. It actually clusters, is what they found. And it clusters in the American South. So the southern counties carry the highest heart failure mortality burden in the nation. So you've heard this term stroke belt and diabetes belt, and that overlap almost exactly in the highest mortality counties of heart failure as well. So this suggests something that obesity and physical activity are upstream things that we can change. They drive downstream the diabetes, the high blood pressure, and in turn drive the heart failure mortality. So this isn't just a coincidence, it is the continuum playing out right before us at the population level. So this is where chronic disease is poorly managed, access is limited, social conditions drive where prevention initiatives are weakest, and then heart failure mortality ultimately is at its highest. All right, so women of color have the highest prevalence of high blood pressure in any US demographic group. And by some measures, more than half of women of color have hypertension rates that are unfortunately higher than any other different demographic. So the decline in awareness that we talked about earlier, that 65 to 44% drop, was steepest among women of color. And so for various populations, awareness is needed promptly, but it's also where it's lost, where individuals lose that understanding and that information the fastest. So heart failure develops earlier and progressive faster in areas where it's rural, systematically disadvantaged populations across the South. So I know even in my own experience, I have had many patient stories where individuals, even at younger ages, have been waiting on heart transplantations. And a lot of it was driven by uncontrolled hypertension, uncontrolled diabetes upstream, and some of the social and structural factors that we talked about making good care, quality care, nearly impossible or just non-accessible. So these are the women, unfortunately, paying the price when we have an undefended prevention system. We need to make certain that we are serious about reducing heart failure prevalence, one, through information awareness, but also those tasks that focus on prevention. And we're serious about closing those gaps. All right. So before we start to wrap up the talk, I want to get in a little bit about some of the major professional societies that have driven a lot of this knowledge. And they're converging on the same message that we must identify stage A and B aggressively. So managing chronic disorders is heart care, and it's not a separate thing. It's not something you do outside of heart care. It is incorporated. And if we want to really think about keeping people on a good heart trajectory, then we have to think about making sure that we have a keen focus on stage A and B heart failure and address those social drivers that shape people, shape our ability to help people as they manage their chronic diseases and putting in clinical interventions and not just a nice to have checklist or things that we add on. Bottom line is prevention is everything. It's the heart failure prevention is key, and we need and as a result, we've been organizing. I know the those societies have been organizing around care systems that help get us away from the wrong endpoint, and that is heart failure. All right. So some of the sources for guidance, the joint guidelines from AHA, ACC, and HFSA were foundational in really truly understanding the aggressive control of blood pressure and diabetes management, as well as the 2020 AHA scientific statement on social determinants of health and heart failure. By Dr. White Williams and colleagues in the multidisciplinary team that pretty much address that social drivers in a with different clinical interventions and heart failure care is important, and it's not something we just add on. It needs to be incorporated. It's not for someone else to do. It's for individual providers and even for patient and individual awareness. And the 2023-24 work from AHA introduced that there are multiple factors that combine and meet at an intersection, including individuals' kidney health, even where our social drivers, where people work, live, and play, their zip code based community indicators that can really predict heart failure and help us focus and concentrate areas on prevention and not just focusing on heart attack and stroke, but also incorporating that within that cardiovascular continuum, a keen focus on heart failure, preventing heart failure. In March 2026, really truly just hot off the press this year, um, uh, I would say over almost a dozen of the cardiovascular societies, including ACC and AHA, came formally recognized and recommended that some of the newer tools that we've talked about um, should be utilized in even individuals age 30 and up. We're starting much younger, and that major guidelines are should be tools that we use to set really truly our focus on how to look at even older patients and patients in specific demographics and signaling that the risk prediction itself has overall changed. The Preventative Cardiovascular Nurses Association and American Association of Heart Failure Nurses also looked and seen how nurses can be very impactful as a preventable workforce. And that because nurses are there at the front line, or at the bedside, in clinics, and in community with our other allied and our interprofessional or multidisciplinary healthcare providers and health workers, that all of us have a responsibility to help engage within our communities and across the cardiovascular continuum, identifying risk and ultimately preventing downstream effects like heart failure. So these different sources of guidance have different vantage points, but they say the same message: defend the heart upstream before we get to the place of heart failure, making certain that we are addressing social drivers, advancing health equity, and recognizing our healthcare workforce working together collaboratively to help move the needle forward. And so I want to talk a little bit and kind of transition toward the end on what actually happens as we begin to do this road and really highlight across the continuum that nurses and other healthcare providers really lead this work at the bedside where screening is aggressive and can be aggressive, I should say, in regards to making certain people, individuals know their numbers, identifying, recognizing, and even uncovering high blood pressure and diabetes. We talked about Life's Essential 8 but also too packaging it, bringing it to light with our patients, so that it's usable and that that it's understandable. We document social drivers of health in a way that triggers action and not just to onlook. We connect patients to resources before they leave in the encounter. This is the clarion call and charge. And in the clinic, we're building social driver screening into our workflows and coordinating guideline directed care across all types of care: primary care, heart care, and even some of the specialty teams. In the community, we want to make certain that there's focus on partnering with health workers and even faith leaders with trusted institutions that reach individuals and really all of us, where we are, where we live, work, and play. And in that leadership space, shaping those protocols that train the next gen of clinicians, and making certain that there's a coordinated effort across the multidisciplinary team that has social drivers, awareness, and that there's keen focus on there. And here's the practical point for that. These new risk tools, every variable they actually measure, things like blood pressure, blood sugar, individual's kidney function, body mass index, smoking status, where people live, as far as their zip code, is information that healthcare workers collect already at the encounter. These are the tools that can help drive this new efforts. And a new way to use that information and collecting it to advocate for cardiovascular care that people, individuals understand. So, excuse me, healthcare workers are positioned at every point on the heart continuum. And we do this work in partnership with whether you're a physician, a PA, a nurse practitioner, a community worker, or at any venture or space. But it's essential to understand that cardiovascular prevention is key and organization around that is pinnacle. So before I close, I just want to talk a little bit about the women who may have found themselves at the crossroads of where this talk, both clinically, lands as it relates to clinical content and just truly the ecosystem of where people live and where they are and where they work and where they play. And it's important to frame this, shape this as what do we do next, right? And even if this doesn't impact uh, any one particular individual, all of us have a clarion call and a charge to do these things right now, today. One being knowing our numbers, our blood pressure, our blood glucose, our cholesterol, our body mass index. We can't defend the heart if we cannot see what's coming up against it. And secondly, knowing our risk factors. What about our family members who have dealt with high blood pressure or diabetes, or even those who had pregnancy complications, um, past elevated readings at their doctor's visit, or nurse practitioner or healthcare provider visit? Asking a clinician, hey, what is stage A? Stage A isn't meant to be scary. It is meant to inform, to allow the patient, the individual, and even as providers for us to take action. And then asking about life's essential eight by name. Many clinicians and some clinicians may not even bring it up, but patients can, individuals can, we all can. The question, where am I on the eight? That's a pretty powerful question. It tells and informs and maybe even signal that one is engaged in their own heart health. And it's an important question to ask. Fourth, don't we don't have to just accept a little bit high as an answer. If our numbers are not where they need to be, if they're off target, then what's the plan? When will we be rechecking? Because our heart care happens over time. It's not at that one particular visit. And then fifth, bring someone with you when you go to your visits. or take notes. We all can do this, whether you're a healthcare provider or accessing healthcare. Cardiovascular care over the years requires memory. There's no single person that can hold that line alone. We rely on our loved ones and those around us to be able to help fill in those gaps and spaces, not only for the family history, but for support and to ensure and for accountability. And so don't carry it alone. And the defense starts right here, right now, knowing what we're defending. So bringing it all together, heart disease is the leading cause of death in women in the US. And heart failure is on the rise. And it's one of the few cardiac conditions where prevalence is actually increasing. So high blood pressure and diabetes are not a small thing. They're common, but they're on ramps to that particular rise. They're common in most populations, but importantly among women. And Life's Essential 8 is a framework. It's a tool, something you can use to measure. And those social drivers determine who has access to that, meaning the success or how well prevention works really truly depends on social infrastructure. What can we do about it? How can we put supports and helps in place? So, this is not a counsel of despair. We are not powerless. Heart failure does not have to be daunting in regards to stage A. We are working more upstream on prevention, and we have the framework. We have things like Life's Essential 8. We have the guidelines from AHA, ACC, and HFSA. We have joint statements from American Heart Association and other institutions like the American Association of Heart Failure Nurses. And we have the workforce, we have the healthcare workforce, nurses, clinicians, doctors, community health workers, those engaged in advocates and policymakers for that women can be able to be the experts on their own lives. What we need and charge with now is the willingness to act on the continuum, the heart continuum, and not just at the end point, to go beyond just the organizing and the awareness and really center our efforts on prevention and helping heart failure not to be a destination. Start putting our bandwidth there and lending and bending toward the trajectory of heart health and not heart failure. That is the case for defending the heart. I'd like this time to take a moment to just say thank you so much for the gift of being with you this afternoon and for your time and your attention. I want to leave you with something that has guided my practice and my own personal mantra as a cardiovascular nurse practitioner and as providing care across my career. Every patient, every individual, every person deserves care that sees them as the whole person. Your disease is not and your diagnosis is not who the individual person is. The person is not their disease. They are living with the disease. They are not the disease. And we can impact and make change. For me, this isn't just a slogan. I've tried to make it a clinical commitment to see the whole patient. And really, as we move forward together, looking at the social, the structural, the clinical factors that impact people. And I'm so grateful for the Georgia Commission on Women for this opportunity and all the partners who made the summit possible. I'm grateful to every single one of you and my fellow clinicians, nurses, advocates, community members, and most importantly, the women who are impacted, but also too will be moving forward with great health, with focus on prevention. And everyone doing this great work every day in serving within our healthcare system. I'm thankful for the opportunity. And here are my references. And please, with gratitude to again to Georgia Commission on Women, to the 444 marketing team, to faculty, staff at Morehouse School of Medicine, and others alike, I want to again say thank you and send an invitation as well to connect. On the screen is my contact information. Defending the heart is the work of many of us and many hands. And as my grandmother and my mother used to say, many hands make light work. Thank you for being a part of this good work, and good night.